Good afternoon. My name is Dr. Chaturvedi. I'm one of the hematologists at Johns Hopkins University School of Medicine, and it's such a pleasure to be here to talk about some thrombotic microangiopathies or TMAs other than TTP. So we're changing tracks a little bit over here. But I'd like to start with a patient case. This is somebody we saw last year. He was a 54-year-old male who had well-controlled HIV but was hospitalized with a kidney infection. He did well on treatment and was discharged, but 2 weeks later, he shows up to his primary care doctor with 5 days of belly pain, nausea, fever, and wasn't making much urine. In the office, his blood pressure was really high at 178 over 94, so he was sent to the ER, where a standard lab panel showed a hemoglobin that was low at 9, platelets were down to 65,000, and his serum creatinine or his kidney function numbers were up. His LDH number was also up, and this is a number that we look for in conditions like TTP, but also related conditions, and it just tells us blood is breaking down, so hemolysis. His blood smear looked very much like a TTP blood smear, where we see these schistocytes and we don't see platelets. And the title of my talk probably gave it away, but this is not TTP, but it is a TMA. And the reason we say this is the TMA is that a TMA is just really a combination of two types of things. One is a blood picture of what as hematologists we call microangiopathic hemolysis, which just means that we see the red cell fragments or the schistocytes, and we don't see platelets. But we also see evidence of some sort of organ damage, whether it is a loss of consciousness or a stroke signifying brain injury, problems with the heart, or in this case, problems with the kidney that is occurring because of a loss of blood supply. So if this is not TTP, what else could this be? And this is an important issue, not just for patients, but also for doctors when we see patients like this, because this is challenging. And this is one of the reasons that even a diagnosis like TTP isn't always made in time, because it could be a number of things, they look very similar. So other than TTP, this could be something called atypical hemolytic uremic syndrome, which along with TTP is the other primary TMA, as we call it. Or it could occur in response to something else. One of the earliest recognized forms was something called sugar toxin E. coli associated HUS, which was essentially a bug that leads to diarrhea, but then leads to a TMA. It could happen in response to medications, bone marrow transplant, or solid organ transplant. In really sick people who are often infected and get something called DIC or disseminated intravascular coagulation, but can also occur if someone has cancer, uncontrolled blood pressure, something called catastrophic antiphospholipid syndrome, or pregnant women with something called HELP that I'll talk about briefly. And this TMA in pregnancy really is a special case, whether it occurs during pregnancy or after delivery, because this is a very high risk situation for both mom and baby, and it's very time sensitive. So why is early diagnosis of TMAs, whether it's TTP or something else, important? The reasons here is that if we don't recognize TTP and treat it quickly, it can be rapidly fatal, and over 90% of untreated patients will die. However, on the other hand, if we don't diagnose a non-TTP TMA in time, other bad things could happen. Someone who doesn't need plasma exchange, doesn't need a big central line in their neck will get it. There are side effects to that. And for certain other TMAs, there are specific treatments, particularly for what we call atypical HUS or AHUS. And that can lead to organ failure that can never come back, such as kidney failure. And you don't really want to be on dialysis if you don't have to be. So coming to TTP and atypical HUS, these are the two major primary TMAs. And we call them primary because they tend to occur by themselves, in contrast to other things that are happening in the setting of severe infection or cancer or transplant or medications that you'd probably know about anyway as a doctor. Now, they look very similar when the patients present because they have low platelets and problems in some organ or the other. But the underlying cause is different. TTP is due to ADAMTS13 deficiency. Atypical HUS is a problem in a part of the immune system called complement. It can either be immune mediated due to an antibody or have an underlying mutation. Both can occur with pregnancy. Both present with this microangiopathic hemolytic anemia when we look at the blood, and both can have neurologic symptoms that can be mild like a headache or severe like a stroke. But here's the key to distinguishing them. The low platelets are more severe in TTP, usually less than 30,000 with the first episode. With atypical HUS, this tends to be less severe with platelets more than 30,000. And atypical HUS, the kidneys take a hit earlier, so you tend to see more kidney problems compared to TTP. And then the treatment is completely different. TTP responds well to plasma exchange and steroids and Rituxan versus atypical HUS that are treated with medications like eculizumab. So that's how we start to distinguish them when we first encounter a patient. Of course, the ADAMTS13 testing does help over here. So let's talk about atypical HUS or AHUS, the other common primary TMA. Now, the most common problems here are the ones we see in the blood with the low platelets and the anemia, and the kidneys. Over 50 to 75% of people end up needing dialysis at least for a short period of time. But I put this wheel up here really to highlight that any organ can be affected, whether it's the brain with stroke, seizures, headache, confusion, the heart with heart attacks, other heart problems, or uncontrolled hypertension or high blood pressure, stomach issues, sometimes breathing problems. So really any organ can be affected, and which is another reason why it's sometimes hard to tease apart what's going on. Now, we talked a little bit about genetic problems. Up to 50% of patients or 60% of patients with atypical HUS were able to find a mutation when we send off for genetic testing. There are often panels that have been prepared of 9 genes or 15 genes or 20 genes as we learn more and more about these conditions. And the most common mutations are found in genes called CFH or the CFH related genes or something called MCP. However, up to 30 to 50% of patients don't have a mutation we can find. The results can take weeks or even months to come back, so that does not really help us in real time. We still need to treat our patients. So we don't wait for these results, and we really treat on the basis of clinical suspicion, and ideally when we rule out TTP, either by getting ADAMTS13 activity quickly or when someone starts plasma exchange and doesn't seem to be working in the first few days. Now, how do these mutations lead to atypical HUS? So in the normal situation, the complement system, which is an arm of the immune system, it fights infection, is balanced between inhibitory factors and activating factors. So they're all in balance doing their job. There are some people who have a mutation that either increases the activity of the activating factors or reduces the activity of the inhibiting factors. So now this complement system is a little bit skewed, a little bit extra activation is happening. It's slightly overactive. Now, this is not atypical HUS yet, but this person is now at risk for developing atypical HUS. And then something happens. That something could be infection, inflammation from a major injury, might have surgery, for example, surgery for appendicitis, could get pregnant, or might have something like a lupus flare. And all of these conditions, even in normal people, lead to activation of complement. But if you're in this middle situation, where you're already at risk for overactive complement, the body can't control it anymore. Complement goes and deposits in the blood vessels and leads to blood clots, leading to atypical HUS. So this highlights two things. One is that the mutation increases risk for atypical HUS, but doesn't actually give the patient the disease. And that's also shown by the fact that not everybody with atypical HUS has a family member who's also had atypical HUS, although the family member probably carries a mutation. And the other thing is that there's often a need for a trigger, such as surgery or infection, to make it occur. Now, what do we do when this happens? Many people start with plasma exchange anyway because we don't want to miss a case of TTP because TTP can be so rapidly life-threatening. But say plasma exchange is not working or we're able to confirm that this is not TTP, then the correct treatment is to give a drug that blocks complement, this part of the immune system that has become overactive. And the drug that first came around to do this in 2011 was a drug called eculizumab. It blocks something called C5, which is a complement protein. And it's given weekly for 4 weeks and then every 2 weeks. It used to be given indefinitely. Now there is a new drug called ravulizumab, which is longer acting. So instead of having to come back every 2 weeks, patients can come back every 2 months, which is a significant improvement for quality of life. These treatments lead to pretty rapid improvement in platelet count, and over a period of time, kidney function tends to improve. Unless treatment was started too late, because in rare cases, we're not able to get the kidneys back. Now, the major risk of these drugs is really that it blocks this part of the immune system called complement. And complement is particularly important in fighting certain infections like the meningitis bug, So there is a risk of meningitis or meningococcal infection. So vaccination is really important. And for at least a few weeks, we tend to put people on antibiotics to prevent this. So what happened later to this patient? He was diagnosed with atypical HUS. He had significant kidney problems, which was the tip-off in his case, and responded really nicely to treatment with eculizumab. Now, 1 year later, we saw him in clinic. He had no problems. Kidney function was completely normal. Platelet count was completely normal. But now he's been offered a great new job that requires a lot of travel. He doesn't think he can do twice a week infusions. So what are our options here? We could continue eculizumab and tell him you don't have a choice. This is saving your life. Stop the treatment and monitor, switch to the longer acting, or either B or C. And I'd say it's either B or C. Continuing eculizumab is certainly an option, but if he doesn't want it, that's not great. We have to make decisions that are congruent with our patient's interests. So we could either stop and monitor, which is a somewhat new strategy, or switch to the longer acting, so he only has to come once every 2 months rather than every 2 weeks. So why would you think about stopping treatment? The number one reason, unfortunately, in this healthcare environment is cost. The treatment costs about $600,000 a year, which is ridiculous. And once a year, I have this conversation with my patients when their deductible resets, because that's a large amount of money. What if the trigger resolves? We talked about how important a trigger is. They may not need the treatment anymore. There is still that risk of meningococcal infection and the inconvenience of infusions. And finally, we now have research data that tells us that this is safe. That said, this is not yet standard of care. But if we do it only if the TMA is completely resolved, kidney function is back to normal or is stable. There is no active trigger. So for example, if it was an infection that caused it, that infection needs to have gone away completely. And the patient understands the risks and benefits and is okay with the monitoring. Now, if we stop treatment, there's an overall 20 to 30% relapse rate worldwide, but it's only about 10% if stopping is done under medical supervision. And in these 10% of patients who do it under supervision and monitoring, retreatment at the first sign of relapse leads to complete recovery for the most part without any other organ impairment. Now, we have learned that relapse rate may be higher in people with certain mutations, so we're more careful in patients with, for example, factor H or MCP variants. And at least in my practice, we tend not to stop treatment if someone has already needed a kidney transplant, because that seems like severe disease. You don't want to put a transplanted kidney at risk at all. So in summary, atypical HUS, the other most common primary TMA, is caused by dysregulation of the complement system. About 50%, but ranging from 40 to 60% have complement mutations. There's often a trigger we can identify. Treatment is with a C5 inhibitor, either eculizumab or ravulizumab. And this treatment is very effective, but comes with risk of infection with meningococcus. And some patients can stop treatment. So now I'm going to move on to patient number 2, who's a 34-year-old woman who's 36 weeks pregnant, who comes to the ER saying, I just don't feel well, I've got a headache. And in the ER, her blood pressure is up to 154/90. We start getting really worried when pregnant women have high blood pressure. And labs that are done show her hemoglobin's down to 8.5. Platelets are down to 13,000. Her kidney function is still okay, and her LDH numbers are up. Now, this is quite a frightening situation because we don't want to risk the mom or the baby. The blood smear, again, looks like a TMA. There are these fragments, and we don't see too many platelets. And that brings me to the fact that the diagnosis of TMA in pregnancy is exceptionally challenging because signs and symptoms of TMAs overlap, and now we're dealing with a time-sensitive situation. Now, these overlapping symptoms are things like ischemic injury to the organs, which means injury due to low blood supply, low platelets, the blood smear with these schistocytes or fragments, and there can be rapid progression of symptoms. What could it be? It could be something called HELP syndrome, which is a severe form of pregnancy-associated high blood pressure. It could be atypical HUS, like we just talked about. It could be TTP. It could be something called CAPS or catastrophic APS. And it could be one of any number of non-pregnancy-related conditions because there is no rule that something that occurs without pregnancy cannot occur in pregnancy, like a drug-induced TMA. So how do we start to tell these apart? One clue might be, when is it happening? Now, TTP can occur anytime during pregnancy, but some of these other conditions like atypical HUS or HELP syndrome or CAPS or catastrophic APS tend to occur either late in the second trimester, the third trimester, or even after delivery. So that might be a sign that you're dealing with one of these other conditions. The size of these circles actually also indicates how common these conditions are. So HELP syndrome is perhaps the most common of these. Now, before I move on to those, I will briefly talk about TTP in pregnancy, just to say it can occur in any trimester. When we find someone has TTP in pregnancy, it could be congenital TTP presenting for the first time or immune TTP. Now, the treatment is with plasma exchange and steroids, always for immune TTP and for congenital until we've established that it's congenital, in which case they might get plasma infusion rather than plasma exchange. And the outcomes for mom and baby, particularly for the baby, tend to be worse in the middle of pregnancy, around the second trimester, between 20 to 29 weeks. And these are results from one of the studies from England. Now, what happens if someone has had TTP in the past and then gets pregnant? We worry about the fact that there may be a relapse with pregnancy. So we like to monitor labs, including ADAMTS13, closely. Some doctors will try to give rituximab before pregnancy to get a normal ADAMTS13 to reduce the risk of relapse in pregnancy. And there's some recent research suggesting that preeclampsia, which is essentially high blood pressure and protein in the urine that occurs during pregnancy, may be more common in people with TTP. So individuals with TTP would just need to be monitored a lot more closely during pregnancy by their OBs and their hematologists. Now, HELP syndrome, this is the most common form of TMA in pregnancy. It's actually the worst form of preeclampsia, so to speak. It's fortunately rare, occurring in less than 1 in 1,000 pregnancies, but can be quite common in women who already have a condition called the antiphospholipid syndrome, in whom it can occur earlier, less than 34 weeks, and that's not good for mom or baby. Usually, HELP syndrome occurs right at the end of pregnancy. Now, I've put the diagnostic criteria here just to highlight how similar they are to other TMAs. There is hemolysis, like every other TMA. Now, the liver tends to be more affected, so liver enzymes go up and platelets are low. The treatment is delivery urgently or emergently. The challenge for us as physicians is, and for the moms that get this, is that if HELP occurs early, sometimes delivering a baby that's 24 or 25 weeks is not going to be associated with good outcomes. So there's actually a study going on at some sites using these complement inhibiting drugs that are used in atypical HUS to see if they're effective in HELP syndrome, because there is recent research showing that complement is involved in HELP. So these studies will hopefully be available in the next year or two. Now, the other pregnancy TMA I talked about is catastrophic APS, which is the most severe form of an immune disorder, immune clotting disorder, called the antiphospholipid syndrome, in which people develop rapidly developing widespread clots and multi-organ failure, which means clotting in 3 or more organs, all occurring within a week, with positive testing for antiphospholipid syndrome in the blood. And in case a biopsy is done, it shows blood clots. We don't have great treatment for CAPS right now. The current treatment is blood thinners with things like heparin, steroids, plus plasma exchange, but that really leads to survival only in about half of patients. Again, research suggests a role for complement in CAPS. So drugs like eculizumab and commonly even rituximab to deal with this bad antibody is often used when standard treatment fails. We're still working on better treatments for CAPS. Now, fortunately for a patient, she was diagnosed with HELP syndrome. The baby was delivered emergently. She was already at 36 weeks, which is fairly safe for the baby. And both mom and baby did well. So you might ask, why do these complement disorders, or why do these TMAs occur so commonly during pregnancy? And the reason for that is that we know that there's some people who are at risk for these conditions, either because they have an underlying mutation that hasn't declared itself yet, or they may have these things like antiphospholipid antibodies. Now, complement can get amplified or increased during pregnancy, and this is an evolutionary advantage in most cases because it might be protecting the mom and baby against infection. But in someone who's already at risk, that can lead to uncontrolled activation and injury to tissues as well as clotting. Now, this is the final patient, and this is unfortunately something we are seeing more and more of as doctors. So, this was a 67-year-old lady that I saw in the hospital. She had metastatic ovarian cancer, and she was receiving a drug called gemcitabine, which is a chemo medication. She presents with just not wanting to eat, nausea, and no urine output. Her blood work also showed high creatinine, which means kidneys are shutting down, low hemoglobin, and platelets that are going down. And her blood also looks like a TMA. Now, I'm going to give you a spoiler here. This was 3 years ago and so far has a happy ending. In a patient with cancer, TMA is actually quite common, can occur in up to 15% of people, can either be due to the cancer itself, which is about 1 in 4 cases or lower, but more commonly due to the drugs we use to treat cancer. And as cancer therapy evolves, there are newer and newer targeted treatments. This problem is actually getting more common. Now it has common features like all other TMAs, like low platelets, schistocytes in the blood smear, and kidney problems. But the diagnosis can be somewhat more challenging because chemo itself would make your platelets go down. Chemo itself can cause kidney problems. It gets a little hard to tease apart what's going on over here. So the causes of TMA in patients with cancer are really in 3 buckets. One is cancer itself can cause effects like causing small blood clots that lead to a TMA. The drugs that we use can either directly injure blood vessels, can cause antibody-mediated reactions, can cause complement activation, and can interfere with something called VEGF that also leads to TMA, particularly in the kidneys. And then, not to forget, primary TMAs can still occur in someone with cancer. No rule that someone with cancer cannot get just standard TTP. Now, anti-cancer drugs, when they call TMAs, they often show up first with some kidney problems and uncontrolled blood pressure. These patients often end up getting biopsies that show TMA in their kidneys. And like I just talked about, diagnosis can be a little bit complicated. This here is a list of medications that are commonly associated with TMA. Nobody ever needs to memorize this. We always look it up. So in patients with cancer, when TMA occurs, what do? The first thing we do is we rule out other causes of either kidney problems and rule out other causes of low platelets. We think about, is there such advanced cancer that cancer itself is causing the TMA? Are they on medications that cause TMA? Do they already have TTP or HUS, and could this be a relapse? And we always check ADAMTS13 because do not want to miss TTP. Now, if it turns out it's just advanced cancer or something called DIC that can occur with cancer, the treatment is to treat the cancer. Sometimes low-dose blood thinners will help. If it is ADAMTS13 deficiency and TTP, we treat it as TTP with plasma exchange and immunosuppression. If someone has known atypical HUS, they get eculizumab. But the biggest category here is anti-cancer agent-associated TMA. Chemo drugs, more targeted treatments. For these patients, the treatments are often supportive care with fluids, blood pressure control. But more and more, we're seeing patients that respond to complement inhibition. And this may either be because these anti-cancer drugs are causing complement activation, or because these drugs or cancer itself could be the trigger for atypical HUS. And we don't fully know that yet, but there are certainly patients that do respond. Our patient was one of them, and 3 years down the line, even with metastatic ovarian cancer, she's doing well on the same treatment. So in summary, in the situation of cancer and TMA, it could be either due to cancer or due to the treatment for cancer. Blood pressure and kidney problems are the most prominent. Always need to rule out other causes of low platelets and kidney problems. And the treatment really depends on whether you can stop the chemo drug, whether we can support the patient adequately, and whether there are other treatments to offer. Something that I'm just putting out here, because you may soon in the TMA world learn about an approval for a new medication, is that people that have stem cell transplants or bone marrow transplants can commonly develop TMAs. They're more common in people who are on immune suppressing medications, particularly drugs like cyclosporin and tacrolimus. get radiation, or develop complications like infection or what we call graft versus host disease. TMA in patients with bone marrow transplant increase the risk of death. Multiple causes, mostly related to damage to the blood vessels, but also a role of complement. And eculizumab has been used off-label to treat this with some good results, but a recent trial suggested that a different type of complement inhibitor called narsoplimab, which blocks a different part of complement, is effective. And the FDA is reviewing it right now. And this is the one you might hear about in the next several months. So in summary, TMA is essentially just what we call microangiopathic hemolytic anemia, which is low platelets and blood breakdown with red cell fragments or schistocytes, along with impairment of any or all organs. TTP is caused by severe ADAMTS13 deficiency and is the number one thing we need to diagnose or rule out. And everyone with a TMA, if we don't know the cause or until we prove that it's not TTP, we treat as TTP. But then the other common TMA is atypical HUS, which we treat with C5 inhibitors like eculizumab. And any other TMA needs to be evaluated in the setting of the underlying condition. Is the person pregnant? Do they have cancer? Did they get a certain medication? And currently, do they have COVID, which can also trigger a TMA in rare cases? And in particular, TMA in pregnancy is a high risk and time sensitive issue. Accurate diagnosis is critical, and these individuals really do benefit from a high risk obstetrics team and an experienced hematology team. Thank you, and I'd be happy to take any questions.